started. Again, want to thank all of you for, well, coming back from lunch and listening to this lecture on first and second line treatment options. And I don't have a great joke like Dr. Moses, other than somebody wants to shout out, "Go ahead, Elisabeth, stand up." And yes, I am standing up. So I'm going to kind of veer to this side so you all can actually see me more than just my head. I hope that this discussion is going to be a brief review on the multiple agents that exist in this space. I really want to thank the committee for inviting me to talk on this issue, and it's something where there's a lot of overlap between what's happening in urology as well as medical oncology and also radiation oncology. So I think the more aware we are as a whole of all of these different options and what the data is that drives them makes us all provide better care for our patients. These are my disclosures, and you could see I have a ton of research support. It's because I do so many clinical trials, which I think gives all of us a lot of hope for the newer agents that are coming into the prostate cancer space. Last I checked, going on clinicaltrials.gov, there's probably over 900 active and accruing trials in the prostate cancer space. So I'd like to encourage everybody to think about either yourself enrolling or at least referring to your patients for studies. And that's how we can advance more of these kinds of newer drugs. So the topic I have to review with all of you today is sort of the M1 CRPC first line and technically second line. And what's tricky about just the language is, all of you know, is just what constitutes that? What is that first line? Because in all of our discussions this morning, it's showing that everybody comes to the story a little bit different. So the classical in the maybe 10, 15 years ago, you have the M1 CRPC, you have a patient with ADT only, and oh no, they're castrate resistant. That's one pocket of folks. We've also heard a great talk on M0 CRPC, so although you can't prove it, they've been on a novel hormone therapy plus ADT. So now you say, well, so when you now become CRPC M1, are you really having no prior therapy? No, you have NHT as a prior therapy, so something to keep in mind. And then, of course, as we heard this morning, the MHSPC is just ballooning all around us. So many people really are not fitting into the classical terms of you've only had ADT, M1 CRPC, and making those decisions as to what you or your colleague or your teammates are going to provide. So my job this afternoon is to really briefly hit all of these agents that are in our space and figure out, in a way, how do we digest this information? Because the good news is we have a list. I remember in 2004, it was docetaxel, and that's basically all I had, and not that many disclosures because there really weren't a lot of activity from a research standpoint. But this is really a very active list, and many of you work with colleagues who administer these, and you could see that, again, from a multidisciplinary approach, it takes medical oncology, radiation oncology, as well as urology to accomplish appropriate treatment. So I'm going to talk about each drug, kind of say what the mechanism is, cite the trial, but then also figure out what does that patient look like? Because I think we're inundated with data. Many of you are aware of them. Maybe some are a little bit more in your head than others. But I think thinking about it from a patient perspective is always really helpful, because they're coming to us in our office in a particular way, and you're not thinking about, well, what is the appropriate trial? You're thinking about, where does this patient fit in their journey and what are available options for that patient? So we haven't really talked much about Sipuleucel T. This is a compound I think that many of you in your urology practices are very familiar with. It's an autologous cellular immunotherapy for men with asymptomatic and or minimally symptomatic CRPC. And again, first in class, originally FDA approved in 2010. And that's the dose. So you get a treatment every 2 weeks, and that's it, 3 times. Many of you do that in your offices. Some of you refer to us in medical oncology. And the trial that really got that FDA approval is known as the IMPACT trial. So Overall survival, 4.1 months longer than with CYP versus placebo. And the updated look-see where you saw the quartile of people that had a PSA of less than 22 did so much better. And here are the curves that we're very familiar with, because you have a hazard ratio that's really quite compelling, whether the person had docetaxel or not. You see the differences in the curves. I want to just take a moment to highlight as well that all the data that we cite are primarily with men who enroll that are white men. So in a lot of the work that I do in Detroit, Michigan, I'd like to know that this data is applicable to the patients that I serve in my community. And I'm going to sort of cite which trial really focuses in on the accrual of Black men, which you know have higher morbidity and higher mortality with this cancer. So in this particular study, even in 2010 and or earlier, really, which is when it began, 6.7% Black men were enrolled, which I think is in a way quite impressive when this was a time where a recognition of that underrepresentation wasn't there. And as such, looking at a registry known as PROCEED, this was really looking at 1,900 men with MCRPC that had at least 12% of them who were African American, looking at what an observational registry that many of us contribute sometimes after the drug's been approved. And the interesting piece is that there was an overall survival that was longer in African American men when the data was looked at compared to Caucasian men. If you looked at the PSA match data, look at that hazard ratio, 0.7, in all patients, 0.81. And I like to call this out because a lot of the times when we are extrapolating data, whether it's in your own backyard or you're giving your professional opinion to those around, it's important to know who's really the patients that were enrolled, because that will help also make a decision in terms of what's available for your patients. So from a patient profile standpoint, what does the person who's perhaps appropriate for CYP look like? Again, asymptomatic or minimally symptomatic. And here, I have to say that gets a little bit tricky. I think we know that men who have a lot of back pain or perhaps they're losing weight, they're not, in that sense, asymptomatic. But it's also just important to know your own definition, because I think knowing that their life expectancy is still over 6 months, great performance status, no liver metastases, and adenocarcinoma versus small cell, it's really still a very viable agent. I know that many of you in the room probably still give it. I think that the thing to do is to monitor so that you can provide the best care. And in this case, we watch again for acute infusion reactions, syncope, hypotension, and you just have to use with caution for men who with risk factors for thromboembolic disease. There are some patients that need central access, so that sometimes can be a hindrance, but for the most part, I think it's still a very viable FDA-approved agent. Docetaxel has been talked a lot about today, and as many of you know, it is considered an anti-neoplastic, so whether you partner with a med-onc or you have a med-onc in your practice or you yourself are approved to do this, just a reminder how the drug works. It binds to free tubulin and promotes the assembly of tubulin into stable microtubules, so then that inhibits disassembly. At the end of the day, it inhibits mitosis. So that gained its approval in 2004, and we give it as this medication IV every 3 weeks, over 1 hour. And these are the two trials that are quite seminal in its FDA approval. You got the TAX-327, and if you remember back in the day, the only other chemo that was approved by the FDA was mitoxantrone, as I affectionately call Smurf juice. If you don't remind your patient that he may pee blue, you'll freak everybody out. So mitoxantrone is still in play, but in the 1996 approval, it didn't show overall survival, it just made folks feel better. So it's important to know, though, what the control arms, because this is the discussion that I'm sure Dr. Scarpetto will have a lot of with the PARP studies in terms of what's the appropriate control as time has moved on. The SWOG 9916 as well. And here we are with our Kaplan-Meier curves. And And in this case, for the TAX-327, you can see that even the weekly dose of chemotherapy shows a little bit of better overall survival. There are many of us that still give weekly doses for those who were a little bit more concerned that maybe they're more frail. So you can see different iterations of how the doses are administered, but typically it's every 3 weeks. If they're more frail, sometimes it's also stretched out to every 4 weeks. The SWOG 9916 as well. And you could see here, I'd like to point out that 15% of Black men were enrolled in this study, which for the SWOG study, I think was a real coup. It really showed their effort to make sure that underrepresented men were recruited. And if you look at a meta-analysis, since we really like meta-analyses, you can see that all of the trials that's listed there, including data from 9 phase 3 studies, there is a statistically increased OS in Black versus white men. So I call this out because we often are under the impression that because there's a higher morbidity and mortality for Black or African American men, that, well, maybe they're too frail. Maybe I don't want to think about giving chemotherapy because of. But when given, especially on a trial setting, in under controlled conditions, you actually see a favored response. So looking at the data, I think docetaxel still has a significant role really in all of our men, but that patient profile, again, symptomatic. What does a symptomatic patient look like? Usually it's, again, my patient who's losing weight, has a lot of pain, has difficulty with his quality of life, and here we want to, again, see that their performance status is adequate, and I'll talk to you about that in a minute, in terms of why we still measure performance status as a tool, because, that's usually the pushback is, well, they're too sick, maybe they're not really appropriate, and we use other parameters in medical oncology to think about what does chemo fitness mean. For patients who have bone and visceral metastases, certainly chemotherapy is there. And just to the right, those are the things we worry about upon monitoring. So when your patients ask you, well, what about docetaxel? Isn't it bad? It's chemotherapy, doctor. Is this really where we want to go? In general, it's a pretty tolerated medication, but I have to say in recent times, there is an increase, at least in my own practice, of seeing hypersensitivity reactions. And once you have a patient that has that and didn't know he was going to have it, or have a family member witness that person having that reaction, you did not do yourselves any favors. So we heavily pre-medicate patients now. We really monitor them during the infusion, slow down the rate, and so on. And some of the toxicities that we've cited in the past include peripheral neuropathy. You can get some rashes or other cutaneous reactions, and you get fluid retention, which is really bothersome for a lot of men who don't want to walk around with swollen legs. But if you, again, teach them that this is something that could happen, even with pre-medication doesn't really help, work with diuretics, have a set time of how many treatments, it's all feasible in terms of administration. If we're thinking about abiraterone, which we've heard a lot today about the novel hormone therapies, many of us try to get the full dose in at 1,000 milligrams. The Cougar 301 and 302 study were really seminal in moving this inhibitor of CYP17 into our prostate space. I mean, it's really everywhere if you think about it, but it really started in the castrate-resistant state. So we used to categorize, again, not so much first, second, third line, but just did you get it before chemo or after chemo? And in this case, Cougar 302 was Abi versus placebo. Cougar 301 was still Abi versus placebo plus prednisone, but it's the pre and the post. So 302 was post chemo, 301 was pre, and you could see that there was an overall survival benefit, which is why it's what you do when you see a frontline metastatic CRPC. The big question always is, how are we doing with abiraterone? So love it, don't love it. There's tons of real world data that's emerging in a lot of places. I think there's a real place for real world data, not to be in place of phase 3 well-controlled, well-designed studies, but it also gives us some idea of what's happening in the real world. So here, looking at a retrospective cohort study using the Flatiron database, it again shows that for their nearly or over 3,000 men who have had no prior chemotherapy, Black men here had a higher median overall survival of 23 months compared to white men of 17 months. Yep, it's just a real world data. We don't have, control randomized trials in this, but it does show you that at least studies are emerging to look at when these studies have been completed and you have an FDA approved drug, how does it look like when you implement it in your own practice? And what does that look like in terms of that patient profile? Again, symptomatic, life expectancy over 6 months, good performance status, bone and visceral mets. But the study that was in the pre-chemo did not have patients enroll with visceral metastases. So just a little bit of, awareness of that. And as we mentioned from the other speakers, there are lots of signs we can monitor for. I think all of us here are pretty comfortable in knowing how to manage the mineralocorticoid excess, whether it's dose reduction or additional prednisone and so on. I just want to put that there are some of our patients that have moderate hepatic impairment. So I do have several patients that end up in the Child-Pugh class B and worse. And sometimes that's not in my general consciousness, and I'm lucky to have a pharmacist that is part of our MDT team that will monitor these things. So it's monitoring liver function, but also recognizing what type of impairment the person is coming in with. So very important to know. And of course, the drug-drug interactions is something we all are very mindful of. With enzalutamide, again, an androgen receptor inhibitor that competitively inhibits androgen binding to the receptors and then inhibiting the nuclear translocation and the interaction with DNA. That approval now is in 2014. And these are the really pivotal studies. AFFIRM and PREVAIL, again, after and before chemo. And then I cite TERRAIN and STRIVE, they're phase 2s, but again, excellently well-designed, well-executed studies of enzalutamide versus bicalutamide. So a lot of data with enzalutamide in the CRPC space. And here you could see again the hazard ratio being really favorable in AFFIRM as well as PREVAIL. Again, AFFIRM is post-chemo, PREVAIL is pre. And I just want to notice that as we're talking and the studies are getting more contemporary, we're doing a little worse in terms of Black men enrollment. So here, you're at 2.4% Black men enrollment. And if you remember, I cited the SWOG study for chemotherapy, 9916, that was at 15%. So I'm taking a moment during this meeting, since all of you see these prostate patients, to try to help improve those numbers in your practice or those in your community so that we don't do worse in the next 5 to 10 years. With regards to the real world study here, another retrospective cohort study, you could see here that Black men in this particular retrospective evaluation had better clinical progression-free survival than white men. Again, would I like to see this in a prospective setting? Well-controlled, well-designed, of course, but there are studies showing that at least in execution, these drugs are very helpful. So that patient profile looks like this: greater than 6 months life expectancy, good performance status, bone and visceral mets, adenocarcinoma. We've heard again about the falls and seizures, major drug-drug interactions. I think everybody in this room is pretty confident about this, but we're, in a way, seeing very familiar patient profiles. I think the last, with Abby and Enza and whatnot, they kind of all look the same. And I'm going to leave that to the good Dr. Lang to talk about sequencing and what should go next. I'm here to just spit out what the drugs are. But in terms of what is that you do when you walk into your practice with these patients, that's where the challenge is, because these patient profiles are quite similar. But not similar, in a way, is radium-223. This is still within our mix. You guys still work with radiation docs that are still prescribing these. Again, this is an alpha particle emitting radioactive agent. It's approved in 2013. Here's how one administers this medication, and it was due to the Alsimca study. As a reminder, that was radium versus placebo. Here are our curves showing a hazard ratio of 0.7. Really has, again, their study of patients that are basically bone-only metastases. It will allow some visceral nodes, but really important to know that in this case, there is a different patient profile. We can accept lymph nodes up to 3 centimeters, which, in a way, by today's standards, is quite large. So you might want to work that out yourselves, but on paper, it certainly is an option. And no visceral metastases, and of course, adequate bone marrow reserve. Something we're thinking about from lutetium's standpoint, we have to keep in mind, because now you've heard me go and talk about multiple agents in the CRPC state. Gets really tricky to make sure that you don't burn out the patient's bone marrow. Again, in addition to bone marrow suppression, we recommend that this drug is not combined with Abiraterone because of an incidence of increased fractures and deaths. And that's due to the ERA 223 study. So really important. And I also don't minimize the radiation protection precautions. The number of patients, whether it's just drug or other theranostics, where that limitation for radiation guidelines is really something significant to the patient. I have to say, I think I underestimate that myself. These are real world issues that our patients have to contend with, whether it's using separate bathrooms and making sure that you're being able to stay away from family members. Again, where I practice in Detroit, it's a real limitation. The one drug we haven't heard about just yet is Cabazitaxel, other than, yes, this is another chemotherapy. This has been approved since 2010, so it's been around for 14 years. Again, another antimitotic, similarly administered with chemotherapy, with docetaxel every 3 weeks. And these are the big studies. Tropic, which is Cabazi versus mitoxantrone, CARD, Cabazi versus Abi or Enza, and then Procelica. And you can see here, again, the hazard ratios are very compelling, 0.7, 0.5. And so the patient profile here is those who have received prior docetaxel and a novel hormone therapy. So if anything, this could be second line. It could be beyond second line, depending on how the patients have come in to your practice. And I'd like to just throw in that we sometimes add carboplatin. This is now NCCN guidelines approved, and you can consider that in the aggressive variant MCRPC patients. So those are folks with visceral disease, with that weirdly low PSA, lots of bone metastases, some of them almost lytic in appearance, high LDH, the unfavorable genomics that Dr. Lang had mentioned. So sometimes we can do both. And so at times, your med-oncs colleagues may end up giving Cabazi and Carbo at the same time. And one of the things we watch out for is neutropenia. So all these patients get growth factors. But one of the things that we often talk about is, how do you know who should get chemo, whether it's docetaxel or Cabazitaxel? I myself use a chemotherapy fitness score that Artie Huria and her team many moons ago had put together. This was published in 2011. And I go through this with my patients who say, maybe I'm too weak, I'm too frail. So, well, let's go through it. Are you over 72? Are you getting treated with genitourinary cancer treatment? Yes. Are you using standard dose versus high dose, like transplant? How many drugs are you getting? What's your hemoglobin? How's your creatinine clearance? How many falls have you had in the last 6 months? I ask that question, it's always a mind boggle, and they go, what does falls have anything to do with anything? Yeah, it's part of the predictors of chemotoxicity. As you gain more points on the right, you can see that if you have 10 to 11 more points there, that you will then have an adverse event grade 3, which is already an admission, 4, or 5, which is death. So if you're saying that, well, my patient looks good, but he's had a fall, he's 75, anemic, really can't do very much because of some whatever other limitation, that person's risk of doing badly with chemotherapy goes exponentially higher. So in that case, it's just another tool to help us get through that discussion with the patient. I know we're going to have a really in-depth discussion with Dr. Scarpato on the PARPs and precision oncology. I just want to mention again, the Abiraterone plus the PARP olaparib is now also approved. So in 2020, there was an approval of olaparib as single agent, but now in combination with Abiraterone in 2023. And that was, again, the PROPEL study. Again, quite robust hazard ratios. So that patient profile is a person with the pathogenic BRCA1 or 2 mutation. Again, novel hormone therapy or docetaxel naive. So I'm sure she'll go into that in more detail, but the one side effect that I think many of you who already prescribed this is anemia, which really is quite sometimes tricky to manage. So here at times we co-manage with our urology colleagues who are interested in doing the combination so that in case there's transfusions or other workups needed, that it's a co-management. Sometimes it's pure management for MedOnc, but here's an opportunity of knowing whether this is something your practice would like to handle or leave to your MedOnc. The other combination is Abiraterone and niraparib, another PARP inhibitor. And in this case, this was also quite recent approval in 2023. This is from the Magnitude study. And again, the curves are really quite compelling. I call out again our shrinking numbers of Black men enrollment. Now we're at 1.2%. So the numbers have progressively worsened. Very, very similar profile, slightly different monitoring here, but we do worry about one thing, which is myelodysplastic syndrome, because that is part of the package insert, but something that we hardly ever see in practice. So I think that's quite important to be mindful of. And then the last combo is with talazoparib, again, just last year, and this was from the TALAPRO 2 study, and you could see that these, again, these numbers are really quite compelling. And here, the difference here is that the alterations of the genes are much more expansive than the last two that I just showed you. And really important as well, because there needs to be an adjustment for renal impairment. So many of you will look at the creatinine and say, yeah, I think that looks good, but make sure to do a creatinine clearance calculation because of the way the dose has to be modified. So that was a real magical mystery ride of all the apparent agents that we have in class. Thanks so much for that assignment. But most of it is really think about how your patient is coming through the story. Is this truly an M1 CRPC? I've only had ADT and now I progressed? Or did I come in with other NHT and or chemotherapy? Then that would make my selection different. The other ones would be the patient factors. Are they symptomatic? Are they losing weight? Do they have visceral metastases? Are they bone-only disease? What's the bone marrow reserve? And then what's the genetics telling us? Somatic and germline. Do you need a combination? Is it just one? What did you have before? And then making sure that the adverse event monitoring ensures your success for treatment of these patients in your practice. So I'll stop there. Thank you very much.